Good morning. Welcome to Grand Rounds. This is really exciting. It's our last Grand Rounds of the academic year. We have just a wonderful speaker today, Dr. Sarah Tietz. A couple of co-presenters whose names are up on the board. I won't even mention them because this is Dr. Tietz's amazing final Grand Rounds presentation. The topic is Care That Ages Well, Program Development Framework for Transforming Geriatric Care. Very excited about this. A couple of announcements. Then the next Grand Rounds will be in September. September 4th, it'll be Dr. Sarah Beck on VA clinical review. More announcements. Please let Elizabeth know about the Rockies game on June 6th if you are attending. Okay, so please let her know by midday today. Is that right, Elizabeth? By midday today. The geriatrics division meeting is today. Oh, okay, so yeah, sorry, that's okay. I was like, wait, what? So please complete the online evaluation or the in-person evaluation if you're here in person today, and then submit questions in the chat or Q&A boxes anytime during the Zoom. Quick introduction. Dr. Tietz completed her medical school, internal medicine residency, and geriatrics fellowship all here at the University of Colorado. Her interest in clinical leadership began in medical school as the first student medical director of Dawn Clinic, a student-run free clinic in Aurora, Colorado. At the beginning of 2023, she became the medical director at AMC Clinic and the director of clinical operations for the geriatrics division, where she's worked to grow the quality improvement program as well as the development of the new clinical programs we'll be highlighting today. We have a strong group of young faculty who are passionate about expanding the clinical care available to older adults throughout our healthcare system. So you'll hear from Dr. Walker, Dr. Johnson, Dr. Clark, myself, Dr. Runkle, and Dr. Blumen throughout the presentation today. A warm welcome for Dr. Tietz. Thank you.
Awesome. Thanks for joining, everybody. We've changed a lot and we've kind of been starting a lot as a division the last couple of years. And so wanted to take some time to talk through kind of what our approach has been to starting programs, and then to highlight some of the programs that we've been using and talk about like the different models and approaches that we've used within those different. So these are the learning objectives to be able to identify some potential models that can be used to understand a framework that I'm proposing today to starting new clinical programs. And then, like I said, to highlight some of our programs. As we've kind of been starting programs, I realized there wasn't really a roadmap that I could find of like, how do you actually start a program? There's lots of different models out there for implementation science and QI, and I'll go through a few of those, but like, what do I actually need to do? What are the steps I need to do to start that program? I couldn't find a good model for that. And so as we've gone through this, we've kind of developed our own model within our division. And so wanted to kind of talk through what that model was today. So we'll talk a little bit about implementation science and QI models. I really think about implementation science as when the solution is known. And we need to figure out how to put that new thing into practice. And then QI is more when the problem is known and we need to figure out what a solution is to that problem. And a lot of times there's similar strategies between the two, but I'll talk about a couple of the models in implementation science, a couple of the models in QI. And then I really think that any change involves a lot of change management. And so I'll talk about John Cotter's Leading Change, 8 steps to leading change. And I really feel like that model has been helpful for thinking about like really how to manage the change that happens throughout development. So the first model I'll talk about is an implementation science model. So this is the PRISM model. PRISM also involves re-aim. And so I really think about PRISM as overall to take a program that we know works and put it in a new setting. And then re-aim is like what we should evaluate when we're looking at that program. And so PRISM looks at both the intervention and recipients of a new model. And so both like who's going to be giving the intervention and then who gets the intervention. And that can be patients, that can be clinics, that can be MAs or nurses that are getting education. There's all sorts of components. And so it really encourages you to think about both like who's going to be doing intervention, and who is the staff managers, leaders that are doing that, or their patients that are going to be doing the intervention, and then who's having something done to them. And then they encourage you to think about all the external factors that really impact your ability to do that program. And so both the like sustainability infrastructure and the infrastructure around that. So like, for example, Hillary in our Living Well with Dementia program that's now Guide is from a program in California called Care Ecosystem. And we used a lot of the same components, but our structure here is different because social work support that we have looks different and the pharmacy support looks different. And so thinking about the structure in which we do that and the environment, which can be the environment of the clinic, the environment of the community that you're in, or you also think about how political environments and support can change recently. And so kind of incorporating all those into the model. And then REAIM looks at reach, effectiveness, adoption, implementation, and maintenance. And those are really kind of the components that you can think about how you're going to implement, and then also how to evaluate if you're implementing. I don't pretend to be an expert in the PRISM model. I think that there's good components to take from it, but I also find it a little confusing how to actually implement it personally, which is why I've kind of developed a slightly different model. So another implementation science model, yeah, you can come up. Another implementation science model is adapted, similar to PRISM, but has kind of different steps. It's mostly been done in like HIV area of research, and that's kind of the model that we've used to reduce program. And so how to apply an adapted implementation science model to that program.
A lot of ways to describe really complex systems, but the simple version is don't always reinvent the wheel. If you have an evidence-based practice, just use it and tweak it to your needs. Most of what Sarah's going to be talking about today are de novo programs she's created from scratch, which is a lot harder, and I like the slightly easier route. But if you use a implementation science framework to choose your adaptations and choose how you adjust a program to meet the local setting, like PRISM, like Adapted, like the SIC model, this does make it easier to then report back, to compare to other sites, and to compare outcomes across application sites. Some examples of what adaptations might look like if you have a nice successful intervention in HIV. That might look like long-acting injectables, PrEP programs, peer support. Some of the adaptations you might make are adapting to the service setting or the location, the target audience, the way in which you're delivering the adaptation. You might culturally adapt to meet the needs of your audience. At times, you may even need to adjust some of the core components of the intervention to meet your needs. Thinking through all of these is a lot easier if you are using it to start with. Adapted is one such example that, as Sarah said, came out of the HIV literature. So real fast, if you have this awesome tool that you want to use, first do a background assessment of what needs are within your setting. Make a decision about whether you want to use the tool in whole or adapt it, or adopt the tool in whole or adapt it slightly to meet your needs. Figure out what type of pre-tested methodology you're going to use to make that adaptation. Create a plan and determine your goals. Gather your experts and subject matter experts and stakeholders. Integrate all forms of information that you've got, so stakeholders, like data, expert input, and train all relevant personnel, and then pilot test before you actually roll it out in full. This is going to look a lot like some of the models that Sarah's going to discuss in later slides. We sort of use this with the aging surgical program. So the American College of Surgeons and the Hartford Foundation has put together a surgical verification program to ensure that hospitals are providing high quality surgical care to high risk older adults. Some of that preliminary work was actually done by Dr. Robinson at the VA hospital. We're rolling this out here at the University of Colorado. Sarah and I are involved in pre-reviewing elective cases to make sure that older adults going into surgery are as prepped as they can be. The way that the American College of Surgeons have set up this program fits nicely into Adapted, in which they recommend that sites planning to make themselves more age-friendly that do a gap analysis of where they're failing to meet the needs of older adults. They then provide a list of geriatric surgical standards for adoption at the local context, similar to what we do with the age-friendly health systems. Their adaptation model is a checklist-style program design because surgeons love their checklists. We got to make sure we're meeting all these bars on delirium prevention, fall prevention, high-risk screening, medication screening. For us, it's the elective review. We'll then standardize the leadership structure, have sites pick self-determined quality goals and tier verification goals. So are you geriatric surgery verified, or are you a geriatric surgery early adopter? Kind of gamifying the system a little bit. The ACS recommends gathering all your topical experts, and what I really like about the geriatric surgical program is it's not just gather your geriatricians and your surgeons, but it needs input from pharmacy, nursing, anesthesia, IT, and you need leadership positions from all of those groups. They then recommend integrating the surgical program into not just workflow, but they have specific EMR-based standards based on what worked and what didn't work at pilot sites. And then additional training, both for our staff, so national webinars that we've been attending to learn more about how other sites are doing their geriatric surgery programs, as well as training for our staff that will be in Zoom, focusing on delirium first. And then we're testing it. So phase rollout to new units and surgical teams. So for our elective cases, I'm currently reviewing a lot of spine patients, and we'll be rolling out more to geriatric oncology and cardiac surgery. One example of how we can take a pre-existing program, they've identified as core components, and following a standard methodology to roll it out here in a way that meets our needs.
Right. So that kind of is the implementation science models. Wanted to talk about a couple of different QI models. And so this is the first, so DMAIC, which I really prefer as a QI model that I like to use. It stands for, you can see on the screen, define, measure, analyze, improve, and control. And I really like this model because it emphasizes the importance of first defining a problem and understanding that problem and making sure that it is a problem. And I say that because a lot of times we come to something with the solution without knowing if we actually have a problem. And so someone will have seen one patient where there was one thing that happened, and then it's determined we should have this big solution for all patients that could possibly have that problem. But maybe there's only 2 patients that's ever happened to, and maybe we don't need a big system change. Or maybe it is a really big and meaningful problem, or maybe the problem is very different than what we thought it was initially. And so I like this model because it really makes you define exactly what the problem is, how big of a problem it is, and then say, before we come to a solution, we have to analyze what went into that being a problem first, and then create a solution based on that, which I do think really helps to make sure that you're getting at the core problem first. And then after you improve and do that solution, then you have control, which essentially means that you ensure that it continues to happen in the future. QI has a lot of other smaller models, and so, or like smaller methodologies or tools that we use. And so just wanted to show a few small things that I'm sure you've seen before. This is a stakeholder power interest grid, which is essentially thinking about different stakeholders that might be involved in a project or program and how to keep them involved. And so different stakeholders will have different levels of interest and different levels of power. And depending on how much interest they have and how much power they have is really how much you should include them in the project. And so the CMO might have a lot of power, but not much interest. And so figuring out how you can consult them and get them to at least loudly support your project or not unsupport your project is important. People who have a lot of power but a lot of interest, so say like you're working in a clinic where the medical director is really interested in making this happen, can make your project a lot more likely. And so making sure you're figuring out how to regularly engage and work with them. There's a lot of people that have a lot of interest that might not have a lot of power. And so you think about staff that works in clinic that may be able to move things forward and help with the project. So important to keep them involved, but maybe don't have a lot of power to say yes or no. And so you kind of think about the way you include them a little different. And then the people have low interest and low power, mostly you just want to make sure that they don't become a barrier. And so that's one tool. I also think about process maps. And really I like process maps because they help you visualize what something looks like. So this is what I created a while ago, talking about how patients get to the emergency department and thinking through where there might be places that we could intervene. So sometimes process maps are a lot fancier. I found out that there's Visio, which we can all get through at CU Anschutz, which can make much prettier process maps. But I think the point is really like being able to write out exactly what the steps are and who's responsible for each step is really helpful. I think a good example of this is we could say like, oh, every patient should get a PHQ-2 and then a PHQ-9 when they come into clinic. Great, but like who's going to give them that? Who's going to put it into the computer? Who's responsible for reviewing that? Who's responsible for ensuring that it happens? And something as simple as giving a PHQ can actually take like a 12-step process from the time the person checks in to maybe they get a form from the front desk and they fill it out, then the MA takes it and puts it on the computer, then I review it, then I give it back and it gets scanned into the chart by the front desk. And so I
Hey
think
Siri, text Michael Page. I wonder if process map for our NMES study.
Jen, I think you're not muted. Perfect. No, all of that, but that's all right. So this is the John Cotter's leading change model. So those are kind of different QI models. And then this is the change management model. And so I really like John Cotter wrote a book. It's called Leading Change. And he has this 8-step model for how to implement change. And I particularly like that this is a focus on like how to really have the culture for change and how to make change successful. So you can have a perfect plan, but if people don't want to do it, it doesn't really matter how perfect your plan is. So the first step is just creating a sense of urgency. Like, why should people change? People don't always like change. A lot of people don't. And so how do you get people to feel like this is something that's important and that they should engage in? Step 2 is having a group of people, so a guiding coalition who can advocate for this and help make things happen. 3 is really having a vision and a strategy. And so like we have a problem is like creating a sense of urgency and then giving people a vision for how it can be better. 4 is thinking about how you communicate and how you educate. 5 is how you remove barriers and empower action so that people feel like they're able to make change. 6 is creating early quick wins so that people are engaged early on and then that produces more change. 7 is consolidating the wins and producing more change. And then 8 is how you really anchor that into culture. And so 8 later is going to talk about how we did this in the emergency department as kind of example of these 8 steps. So this takes us to my framework called the Tietz Clinical Development Framework, so named for today's presentation and made up by me. And I do think this is kind of what I've used as an overall roadmap of how to approach program development. I'll say nothing in here is novel or new. There's no like rule that I developed within this. It's just kind of how how my brain has organized to put things together to create a program. And so wanted to kind of share. I think a lot of these steps were learned by not doing them right. And then the next time figuring out you should really do them better. So probably in 5 years, this will look a lot different as we learn more, but this is kind of what we've done along the way. So it's a 7-step model. The model really starts with understanding current state. And so like I talked about in the DMAIC model, I think it's really important to understand where we're at now before we start implementing change. And that can use a lot of different tools like process maps. I think it's important to understand the current state in terms of literature, of what others have done throughout the country and the world, and things that we could learn from that. Making sure that those who are involved in the current processes that you understand their perspective. So thinking about some key informant interviews, really doing a needs assessment of do we need this change and how do people view that and how many patients could this impact? And then making sure you really understand the problem with baseline data, understanding the scope of your problem and who you're going to involve. And I think this emphasizes really starting with understanding the current state before starting with solutions. And people get so excited about solutions. So I think it's really important to like make sure that you're stepping back and first understanding current state. Next is understanding feasibility. And so is this financially feasible, but also is this feasible, like culturally feasible? And so, and this is really like a hard stop area. So if this isn't financially feasible, in that you don't have support for this, or it doesn't make enough money, or whatever it is, or if the place that you're doing it isn't open to change, the culture isn't respected, you don't have executive sponsorship, and people don't want you to do it, the program won't be successful. And so if you don't have feasibility, I think you really have to take a step back and say, is this the right time? Is this the right project? And should I shift somewhere else? Then it's involving stakeholders and understanding your stakeholders. And so really, as you kind of understand current state, like collecting, like who are all the people involved, who are all the people who would need to be involved in this project, and making sure you're involving them early and often. And that's from everyone from the local leadership and within the clinic to broader leadership, to the staff that will be involved, to consultants that you'll involve. Really making sure that you're thinking about like everyone that this will touch. If you don't involve them early, towards the end, when you're rolling out, they'll come to you and say, hey, but you can't do this because of that. And then you're like, oh no, what am I going to do? So if you address those concerns early, it makes things a lot smoother. So involving people often, I think. And then we get to solutions and workflows. And so I think coming up with a solution really involves like process maps, understanding from the very start to the very end. So if you think about a new consult clinic, like how will you get the consults? How will you identify patients? Who will schedule those patients? What will your schedule look like? When they get to the clinic, who will check them in? What do they need to fill out? How do they get to the room? What are you going to do in that visit? What do you need to do after, and who follows up those? How are you going to get back to the primary team? And so like really thinking about every single step. That includes scheduling logistics, billing logistics, and that involves all the consultants and multidisciplinary team members who would be involved. And so really thinking through like every single person that's involved in the step and making sure you've thought through all of those components. Once you've thought through all your workflows, I think creating tools is a lot easier. And so I think about this as like Epic or electronic health record tools, and then also like physical tools. And so do you need a flow sheet? Do you need to create a schedule template? Do you need an alert that pops up? You know, all those things. And so if you have your workflows really well laid out, it's kind of clear to see where along that process you need a new tool. And I think Epic tools take a long time to build, longer than you would ever think. And making sure that your request is specific and exactly what you want is helpful, because if you request it and then request a change, it might take another year for that change to happen. And so really requesting early and often, and making sure that when you're making the request that you know exactly what you want, and that you'll use that tool, I think is important. And then what are all the other tools you'll need? So are there patient handouts, educational materials? Are there signs to put up? Are there note templates to create? And really, as you're making the solution, saying, what are all the tools we need? Last two, program evaluation. And so for program evaluation, I think it's really important to understand what key metrics you should be evaluating. So often that's looking at like a literature review to see what others have evaluated in similar spaces, or what people locally or executive sponsors care about and they want to hear about to understand if your program's working well. The re-aim model, I think, gives you some components that you can use. And then the part that I failed at in the emergency department is who will actually do that evaluation and how will that work? And so we had all of our metrics we were going to do. We had a great plan. And then we're like, we actually don't know how to decide if these metrics we've collected work. And so are you going to do a pre-post evaluation, a comparison group? Do you need propensity score matching? Are you capable of doing that? Should someone else do that? Who could help you? And having that plan up front and involving those people up front, I think really helps you do a better job at tracking those metrics. Thinking about how you'll get those metrics. And so that the things that you want to track is in a place that can be easily pulled, or that you're tracking prospectively instead of requiring like chart reviews later. And then making sure before you start, you really have a timeline for that evaluation and a plan for it. And then lastly is change management. So we talked about the John Cotter's leading change management model, but really thinking about like, what is your plan for support and buy-in? how are you going to celebrate wins and when, and having those time points set out ahead of time so that you can celebrate really small wins early on, and then people will get excited. So an example of that with delirium is we are going to, in the first week, anybody who just has the flow sheet that we want them to use wrenched in, we're going to go around and give candy to. So like really small wins early on so that people are excited and engaged. Making sure that you know who your dissenters are early. So for example, orthopedic surgeons for delirium, or, you know, who really are like, this isn't my problem, which is fine. But like, how do we at least like have them be not a barrier, and feel like this is an important thing for them to allow to happen with their patients. So engaging those dissenters early, and then thinking about communication, education, rollout plans, and thinking about how to market to the community, to other providers if you're a consultant, really what your kind of marketing strategy is going to be. So that is the general overview of the process. And so wanted to kind of talk through some of the programs that we've started and then what these different steps can look like kind of in real life in our different programs. So I will say before that, that there's a lot of steps here and that real life is messy. And so don't let perfect be the enemy of good. I think it's really important to think through things and to have an approach and plan ahead. But I also think a part of this process is making sure that you're flexible and that you're engaging people who are supporting you. And if you're starting a process and the way that you're thinking that this is going to go isn't working out, to like transition to the place where there's least resistance. And it's really better to have like an imperfect model that everyone's using than it is to have a perfect model that like nobody's willing to use. And so I think really like making sure that you're flexible in this process is important. So first wanted to talk about current state and feasibility with our Falls Clinic that Thomas recently started. So I will transition to Dr. Thomas.
All right, so I'm going to talk about these first two steps in regards to the fall prevention clinic that we've been doing as a team for the last several months. And so the first thing we started out with was the current state analysis. As Dr. Tietz mentioned, that's just kind of understanding the lay of the land, what things are looking like currently. And so I did a lot of process maps, way too many, probably like 6 different iterations, and walked through that with different team members to see what am I missing, walking through the clinical staff, different groups to make sure I'm getting every single step and understanding those tension points. I also wanted to understand the problem and really figure out, is this a problem that we have? So I did a big literature review, also looked at data nationally, locally, and within our system, and then also did some key informant interviews through a presentation with at the provider meeting for our seniors clinic providers. And then finally, we did a needs assessment, which I'll walk us through in a second. So kind of looking at the national data, we know that every second an older adult falls, and that results in 32,000 deaths per year in the United States. It's also really important financially. It's estimated that falls cost $50 billion annually in the US. So I knew this was a problem nationally, but I did want to look more local in Colorado. So we know from 2020 to 2023, there were over 4,000 deaths attributed to fall-related injuries, over 300,000 emergency department visits, and 44% of those in Colorado were in the Denver metro area. So highlighting that a local clinic would make sense, or a local action. Didn't know clinic was going to be. However, when I looked at the guidelines, the USPSTF guidelines actually recommend that clinicians individualize a decision to offer multifactorial interventions to patients with high fall risk. We didn't really have an opportunity for that outside of the VA at this point. So we were missing one of our recommendations by USPSTF. And so then I kind of pivoted, what about our local context? So I did a needs assessment. This needs assessment was a survey I sent out to Anschutz seniors clinic providers, Anschutz internal medicine providers, and Lone Tree family medicine providers. And we actually got 30 respondents, which was way more than I was expecting. And I wanted to understand what, if this was a problem that our providers thought was important to deal with, and would this be useful?
And so 87% of providers thought that they would refer at least one patient to a fall prevention clinic once per month. So this shows that there's a numbers need for our patients. But also, we learned that there's an expertise need. So 87% of the respondents stated they would like assistance with physical performance assessment and assistive device recommendations, and 63% desired a comprehensive medical assessment related to falls. So this shows that expertise was needed and desired by providers in their busy clinic schedules. So we had this understanding of the current state, what things looked like now. But like Dr. Tietz said, we have to know if this is feasible, right? We can't go any further. And so I spent a good chunk of time on the financial feasibility, which we'll talk about more in a second. And then also trying to understand, is this the right time for a fall prevention clinic? It had already been done before. Is this the time to bring it back or not? And so really trying to figure out, okay, how would we get these patients? Really thinking about initiatives at the health systems level. Does this align with things in our division, things within our health system, the Colorado Moves initiative, these different things? Would people be interested in? And also trying to understand, are the seniors clinic providers interested? Are there other PCPs interested? And trying to understand our whole team. Who else will be impacted by these changes? PT, behavioral health, but also looking at our clinical staff, our MAs. And so I really took some time to do the financial modeling because this was the most important. And so I knew I wanted these 60-minute visits. And so I took that and looked at my work RVU benchmark and tried to calculate, okay, how many patients would I need to get scheduled? Because I was worried I'm not going to have any patients actually referred to me ever. So trying to make sure I could meet my work RVU benchmark so that everybody was happy. Dr. Tietz is happy, the board is happy, making sure all of my stakeholders understand where I'm at. So to the right is different case mixes that I calculated with different billing codes. I also worked with the Office of Value-Based Performance to try to see, okay, are there Medicare Advantage plans that have quality incentives that we could tie into this? Unfortunately not. But I worked really hard and kept emailing them over and over again, different things that I found that they said, that doesn't matter, that doesn't matter. But at least we tried. Also explored some different multidisciplinary clinic billing codes that we can utilize in the future. And then came up with some contingency planning. What if I only get one referral for a clinic that week? So coming up with backflow plans. I think one of the biggest things that I wanted to do is kind of take lessons from the lean startup. I think we're doing like kind of a Harvard Business Review summary today with change management, lean startup. So looking into the lean startup to try to launch this clinic. So the concept with that is to get your process out there as quickly as possible and rapidly have iterative development to continue to change whatever your product is, but getting it out there quicker instead of having the perfect polished product. And so I knew my goal was to have a multidisciplinary clinic eventually. That involves a lot more people than just myself and puts their work RVUs, all these metrics at risk if this isn't successful. So I got the clinic out there as quickly as possible, just as a soft launch with just me. And that's what we've been doing for the past several months. And that really worked as just kind of a proof of concept. As soon as I started seeing patients, I was changing my note templates, meeting with our team, making sure that we changed all of our processes, changing our educational materials. And then since that's been successful, we've had a lot of patient interest, and a lot of patients have said that this has been useful, and we've had good referrals. We're going to start our full multidisciplinary clinic at the end of June. And so we'll have a medical evaluation, physical therapy evaluation, and psychology evaluation for all of our patients that are referred to us.
Wanted to talk about how we have thought through coming up with solutions and how we've created tools for those solutions through one of our other programs. And so that is Dr. Devin Gilhooly and Dr. Sophie Clark, who are starting our geriatric oncology clinic that's coming soon. So we're kind of in the throes of this right now, honestly. And so they were going to talk through how they've thought through those steps.
So Devin, Sarah, and I have been working with two oncologists to create the Geriatric Oncology Clinic. And so really one of the main things that we are very immersed in at the moment is understanding how to integrate ourselves into the oncology clinic. So we're used to being in the seniors clinic, we're used to being able to measure gait speed and thinking about some of those very geriatric specific measures and realistically what can be done versus not done in the oncology side. So some important questions we've addressed is thinking about how to choose our patients. So we can't see every single older adult diagnosed with cancer. So thinking about being thoughtful in how we select those people, trying to think about the nitty gritty of the clinic, thinking about the check-in process, who to involve in clinic. Do we actually need physical therapy there in clinic, or can we just talk to them afterwards? Thinking about the scheduling process, thinking about the different EPIC processes, and then also thinking about how to communicate this information to oncologists, thinking about how we can give them the information, making it useful, but also not placing bullets. So our new process that we are proud of, but have not actually used yet, so hopefully this actually works, is we identified the G8, which is a frailty measure that's validated in the oncology group of people to identify people who are at high risk for side effects from treatments. It looks at a lot of the common frailty measures, looking at functionality, looking at weight loss, looking at dementia, polypharmacy, things like that. And the score is backwards. So lower scores are actually worse. So any score less than 14 is bad, higher scores are good. So we took this screening tool and we created an EPIC flow sheet for it. And so same measures as in the previous slide, but the really cool part about this is some of this is automatically filled out and pulled with data from EPIC. So like it automatically populates the BMI, the age, looks at the med list, or there 3 or more meds, and then even does things like looks at ICD codes for dementia, and then triages it based on like mild dementia, moderate dementia, like severe dementia, and populates that. And so the actual number of questions that patients have to answer are minimal. And so that will be sent as a patient questionnaire before their via like the e-check-in process before their first oncology visit.
All right, so this is a little bit of a clinical workflow that we identified. So we're looking to capture frail older adult patients, so anybody over the age of 65 with GI, GU, or breast cancer. And those are going to be the targeted oncologic specialties that we first reach out to. And so we're looking to capture those patients initially. As Dr. Clark mentioned, we'll be utilizing the G8 tool where it confusingly, a lower score is higher for frailty and thus positive. And so these patients the patients who have a G8 score of less than 14 will have an automatic triage of their chart and referral to the geriatric oncology pool, which we've created, where our team, as well as the oncologists are supporting this, Dr. Liz Kessler and Dr. Enrico Soto, we'll get together for a weekly review, look at those cases, decide which of those triaged patients are most appropriate for our clinic, recognizing that at the outset, we'll have a half day in the morning. So we'll likely be seeing 4 patients a week, 16 patients a month in these 3 specialty clinics. Hopefully that will expand considerably over time, but recognizing that that number does not capture all of the older adults within these specialties receiving chemotherapy. We'll identify our patients. They'll receive a full geriatric assessment in our dedicated clinic, which will be an oncology specialty clinic here on the 2nd floor of our cancer center. And then, as Dr. Clark mentioned, we're providing treatment recommendations, interventions back to the primary oncologist. So we'll talk a little bit about some of the tools that we're utilizing, for our clinical workflow. Obviously, the G8, I think, is one of the most important elements of this clinic, and we'll be tweaking things. One thing in particular is looking at the importance of age according to cancer type and how we will utilize that G8. So, for example, patients with breast cancer, that age cutoff may not be 65 because those folks are going to be healthier. So we may be looking at 75, 80, right? Versus potentially 65 for other types of cancer like GI, where we may capture more frailty in those patients in their 7th decade, for example. Some of the other tools are, for one, a non-interruptive best practice alert. Those BPAs we're all very familiar with in the electronic medical record. We're not looking to disrupt the oncologist. We really want this to be a supportive practice, and part of that is not interrupting their oncology practice, but providing information and awareness about what is happening with our geriatric oncology clinic and the patients that will be triaged appropriately. We are generating an additional consult referral. Obviously, I mentioned the in-basket pool in the inbox message sent to our team. A separate consult referral for the oncologist in case they do separately want to refer frail older adults to our clinic. You know, the note template, I think, is a really important thing. We've had to look at a number of different tools that are validated in the geriatric oncology space to be used in this clinic. And I think we're going to utilize a number of things, but principally the Cancer and Aging Research Group, the CARG geriatric assessment tool. And that's going to be, I think, a very helpful element of our new Geriatric note template. Some of the non-EMR tools are just provider handouts, patient handouts, making sure that people have an understanding and awareness of what this clinic is. So putting this all together, kind of coming back to our workflow, you can see that some of the things we've mentioned on the previous slide, the screening tool, notifications to oncologists, epic messages, the option for geriatric referral, the new note template, and the patient and provider handouts all fit in seamlessly to this workflow. And so it's been very helpful to walk through this and then to think about where do these tools go. And obviously, I think as has been said quite a few times, this is an iterative process, and I'm sure there's going to be many more tools and steps of this workflow along the way. In particular, that full geriatric assessment scheduled in the dedicated clinic, that has its own process map and workflow. So thank you.
I think one thing that we've done well is thinking about what barriers there might be and then making sure that the workflows work around those barriers. So an example of that is instead of asking oncologists to send us referrals and hoping that we get referrals, we're just having a tool that automatically gets sent and then having that automatically come to us, which is a strategy we used in the ED too. So we kind of show up and try to be helpful and then hope we win people over along the way instead of having to prove we're helpful and get people to refer to us. So Kate's going to talk about some of our process in the ED of engaging with stakeholders, which she did a great job of, and then how she implemented change management.
All right, so talking about stakeholder engagement, this was crucial to the program. Obviously, we were trying to implement something within a different department, and so that's a huge part of making sure something's successful. So certainly involved the leadership and the providers within the ED, but also within the seniors clinic and making sure everyone was on the same page. I also made sure to really include everyone else in the ED beyond just providers, because I knew obviously geriatrics is multidisciplinary, wanted to make sure that we had involvement from a lot of different groups, which there's a lot of players in the ED, including palliative care social work, PT, RN, pharmacy, just to name a few. We're also able to get stakeholder commitment from the Department of Medicine by presenting at Shark Tank in 2023 and winning that competition. So really got some involvement there. And then also involvement for direct mentorship from Dr. Goldberg, who I think hopefully we're all familiar with. She's a physician in the emergency geriatric space. So this is just a demonstration of some of the meetings that I had, just to demonstrate the longitudinal aspect of trying to involve multiple players and having iterative meetings to make sure I was eliciting all of everybody's concerns and different opinions. So just a visual to imagine how many meetings you really need to have when you're trying to implement something new. So to go back to the leading change model that Sarah already talked about, we really use this to develop the ED program in a very thoughtful, stepwise approach. So the first step is to create a sense of urgency. Unfortunately, our whole hospital is always at a state of crisis in terms of boarding and volumes and throughput for our patients. So this is a well-known issue amongst all hospital leadership that this is a challenge. We also know from geriatrics perspective that we would really like our patients not to be hospitalized unless they need to due to a lot of high-risk aspects of those admissions. So we had an easy sense of urgency buy-in from both sides of the hospital and the seniors clinic side. Creating a guiding coalition, these are the critical people that we involved from the very beginning, clinic leadership and ED leadership. This was critical to make sure that everyone was on the same page and agreed with doing this implementation, and we would not be here without this group of people on the slide. So developing a vision and strategy. Some of those stakeholder meetings were also a marketing strategy to say, hey, this is a thing that we're doing. I hope you're excited about it. And now you know, and you have a face to the name of who's going to be starting this program. We also talked to a lot of people about what the most helpful consult would be, getting feedback actually in real time from providers about what they were hoping for from a consult, and also getting feedback from senior care providers in the same way. We did create a process map, as we've talked about previously in this talk, and had to update that and make sure that we really understood the workflows within the emergency department and after patient level PD. Communicating a change vision is the fun part. So I got to bring geriatric themed food like pie and old fashioned donuts to the ED, and also communicate the number of consults we've done, the number of patients we've avoided admissions, and help just keep this a fun, interesting process so people view us as helpful, and bringing food is never a bad thing in healthcare. For broad-based action, this was one of those tool development things that we really needed Epic support to make sure that this was a sustainable program. So we got this auto notification through Haiku, which is honestly essential to the program functioning. I also worked with CU Medicine extensively to optimize our billing to make sure that we were actually getting paid for all the effort we're putting in, and then developing a data set that was also extensive within Epic to get that support. So the last 3 steps are on this slide. Generating short-term wins is also bringing candy every time somebody puts in a consult, so they have a positive association with our consult order. That's usually Werther's or strawberry candies. Consolidating gains was presenting at multiple conferences, so we were able to summarize some of our data at Shark Tank the following year to demonstrate that we really did make a difference for a large portion of patients, and then presenting at national conferences in the last few years. For anchoring new approaches in the culture, this is the part that I'm the most proud of. So our goal is to obviously reduce cognitive burden on the ED providers. We expanded to non-seniors clinic consults in January of this year, and we're getting de novo consults now from providers, knowing that we're going to be helpful and they know what service we can offer. And also, I have embedded, that's from the emergency cultural side. I think we also were able to conduct a survey demonstrating that nearly every attending in the ED thinks we're valuable and would like us to be expanded. And then from the clinic side of cultural, embedding this culture, we have a bi-monthly meeting where we talk with care management and our PCPs about high-risk utilizers and how we can make some changes to help avoid ED visits and therefore admissions. And then I do an education lecture once a month on interesting cases, both from an ED management perspective, but also a clinic follow-up perspective, really to try to embed the cultural change of our collaboration with people throughout our whole clinic.
Called you Kate Nevertheless by Dr. Kate Winkle. And lastly, Dr. Blumen is going to talk about our program evaluation of the VESPA program. I will say program evaluation is the thing that comes least naturally to me, and so is the place that I partner the most, because that I find the hardest. And so appreciate Dr. Blumen's expertise in how to think about a program.
So I think most people are familiar with our VESPA program. It's our elder abuse consultation program. And what is different about this program, although similar to the others, is that it's really a new type of medicine. So there's only 2 teams in the country. So when we were starting out, there wasn't good consensus on what were the outcomes we needed to measure. What does success look like in this space? I remember Bob once telling me, he's like, you're not going to fix elder abuse. So what are you going to measure? And I was like, okay, a little bit of nihilism, which is always good for thinking. And so from the beginning, how we thought through things was, what are we going to evaluate? How do we get that? And then how are we going to get that data evaluated? And what I found most helpful in working in our space is always trying to balance, who is the audience? Who's this going to be important for? And in our realm in particular, we really have to think about not just healthcare, but also these other very large sectors, including protective services and the legal system. Because a lot of what our patients need to stay safer and to have better health outcomes are really dependent on these other partners. I can't put in protection orders. I can't do home visits. I can't do a lot of the things that my APS workers and my police officers can do. So thinking through this really every level, and then also understanding that those systems, just like healthcare, have different goals at each level, the worker, the local offices, and then the larger systems. And so when we were thinking through who's the audience for our program evaluation, I think the first people I always think about is our own program. And so how do we know we're doing a good job? We're not causing unintentional harm. We are benefiting patients and providers. So what do we need on a quarterly, monthly basis to know that the train is on the tracks and we're not going off the rails? Then I'm back to think about how do I convince other providers to care about something that they would rather think doesn't happen? So what is going to make them think elder abuse is an important thing and that we can actually change things? And because those are kind of two little steps before I can even get to the patients and families. And then we want to think about, of course, what's important to them, which is not necessarily what's important to other stakeholders. So a lot of our patients, mortality, safety are not their topics, right? It's quality of life, it's autonomy. And so thinking about that. And then thinking about what's important to our hospital or healthcare system. So as Kate mentioned, our hospital is always at capacity. They really care about case mix. And so what bed is being taken up by what kind of patient is really important to them. So speaking that language. Similar for insurance and policymakers, I think those are a little bit more aligned of what does this person look like? How many people are ending up on Medicaid because of abuse and the system impact? And then what's going to be important to researchers and then other health systems to think about implementing a similar program if it's successful. So thinking through each of these levels and each of these sectors. So the kinds of data that we collected, and we really designed a lot of this from the beginning. So we designed some process data from the get-go. So we started with qualitative data. We have a provider survey that goes out to healthcare providers in our hospital, also caregivers, APS, and law enforcement, where we can get immediate feedback of what's going well, what's not going well, what do we need to change. We also have a patient data registry, which helps with grant reporting and can also give us some run charts. So we have like a weekly, how many consults are we getting? What types of consults are we getting? What is our rule out rate? So right, about 20% of our consults, we say there's no concerns for abuse, which we think is reflective of getting appropriately consulted. And so we have that patient data registry, which then has allowed us to do some more beefy analysis using health data compass data, looking at our single site, comparing patients to trauma victims or assault victims without VESPA involvement, to look at initial effects of the program, and then really laying that foundation for more dramatic trials, formal research type programs. We've been proposing in NIK and other things, be matching eventually a multi-site pragmatic trial. So thinking through this from the beginning is really helpful because without our data registry, we wouldn't be able to do trials really. And so thinking through this is really helpful.
So this is the framework. I guess I hope you all can see that there's a little bit of method to the madness of starting these programs and all the random things people are doing. This is my first time presenting this as a model, and so would really love feedback. Would love to hear what others have done in this space in terms of program development. I know there's lots of expertise in program evaluation, and so happy to connect or hear feedback. We have a lot of partners in a lot of places, and this is just a small list of them, but wanted to make sure that we acknowledge and thank all the people that we've worked with because we've had really awesome partnership in so many different places. So with that, we'll take questions. Okay, I'll repeat it just in case.
First off, great presentation. Two things struck me. One, I find it really interesting that there's nothing out there, like your first statement when you went up there, you couldn't find any existing framework. I think that this shows that there is a great need for this to be you'll know if you disseminate it. Because there's a lot of people you're interested in, based on data that's kind of big.
Maybe after today, someone will tell me there is this framework that I know about that you were unaware of, and if so, great.
I think it speaks to the need to like, I'm serious. Yeah. So my question though is related to the cancer. So in the news, Joe Biden just got diagnosed with prostate cancer, very common cancer, most common cancer on that. But it wasn't in a high frailty rate. But that's not one you're focusing on. Do you have plans to expand, or can you talk?
To let Dr. Tietz as well answer this question, but I think some of the key elements were rates of chemotherapy use and the number of chemotherapeutic agents in those specific cancer types. Specifically thinking for chemotherapy agents. Prostate cancer, obviously, we use a lot of antiandrogen therapies. There's less toxicity with those. There's more opportunities not to provide a lot of chemotherapy for metastatic hormone positive prostate cancer. So I think part of it is just the cancer type. But I do anticipate that the goal really is to be able to spread this geriatric oncology practice across all cancer types. And part of what we're really looking at is stakeholders who are willing to pair with us as geriatricians. And ideally, I think we'd like to see this as a multidisciplinary approach where we are embedded within the first oncology consultation. So instead of having the patients check in, get a score, and have a post-initial oncology consultation with us, be a part of that initial process so that we can really inform those initial recommendations. So part of it is just stakeholder engagement, I think, and part of it is cancer type at the outset.
I think that's great. I think we really went where people are interested in working with us. Thank you for the comments on the model. I will say, after I had created this and then went to AGS and they were talking about AI, I typed into the chat GPT, give me 7 steps to create program development. And it was like awfully similar, which was a good reminder to use tools that are available to you and a good reminder that like all this information's out there, but maybe not collected exactly like that. But that was a humbling moment. Like ChatGPT can give us in 2 seconds. So, but that also means you can use ChatGPT for complex things like this, and maybe that is a tool that you can use if you're starting. Yeah.
Great presentation. I was curious, and I think it came up multiple times, this idea of iteration, and also how there's actually this through line where when you get to program evaluation, you realize the outcomes matter to the stakeholders, and it kind of comes full circle. I'm curious to know, since you've now spoken with so many people throughout the university, how have people been responding with regards to like the outcomes they are interested in? Like, what are you feeling is like the timbre of how people are perceiving geriatrics? Are they saying, oh, well, sure, just sort of like figure it out, manage the finances? Are they saying like, no, we really have a clearer idea, or they're looking for us to give the idea as to what the outcomes are? So I was really curious to know, as you've gone through this, what have been the outcomes that you, the university?
Yeah, I think there isn't one metric that everyone cares about. And I think a part of the strategy is telling the group that you're talking to the metrics that they care about. So when you're talking to Dr. Kuttner, talking about length of stay and cost and readmissions, because that impacts cost. And when you're talking to the PT on the floor, talking about falls within. And when you're talking to the social worker, talking about the impact that those are having on patients and families. And so I think it's really important to like have the metrics that you're thinking about and tracking, but making sure that you're like speaking to the audience that you're speaking to. And sometimes you have a large audience and you have to kind of speak a little bit to all of it. But like Elizabeth talked about, like when we give a presentation at APS, the things she's going to talk about will look quite different than to law enforcement, will look quite different than when she's talking to the hospitalist. And making sure you're kind of editing for each venue, I think is really.
Great. Thank you so much. It was really fun to hear from everybody and see the happening. So thank you for that. What great scenarios for those programs here. So one of the things we're really trying to pay attention to in the research world is engaging patient and caregiver stakeholders. And so I was just curious, through the programs, are you engaging them? I realize you have to make a case to the system before you can do any of this, but is there a plan to engage patient and caregiver stakeholders, or have they been engaged? And then what about measuring patient and caregiver experience through the whole thing? And then the reason I think about it for your clinic is these are frail older people who are now coming to yet another visit and in a different building than seniors clinic, and all of just the things that add up for those folks, and how they're helping, how you all are helping them navigate those additional burdens.
Do you want to check that in Geria? Yeah, I think it looks a little different in different places. Most places that have a clinic visit have an associated survey that goes out after, so I think that's helpful. On VESPA, we have sent some surveys to patients and families, not routinely because it's complicated, I think. But, like we've invited the patient voice to the summit, and we've tried to be thoughtful about the patient experience, but it is a hard thing, I think, to capture and measure. And the number of surveys patients get is really, really high. And so I also think we think about our patient and family advisory group and going to them and getting their input. So it's a smaller group of patients.
Well, I think specifically for the geriatric oncology program, the goal would be incorporating social work, I think, is really important while pairing advanced care planning. And so identifying the caregiver, the power of attorney, the individuals that support those frail older adults initially, so that we have buy-in in terms of how do you support those patients. The goal really, I think, is, while it is an extra visit and more information, the literature is pretty clear that for older adults facing cancer or chemotherapy treatment, these types of consultations reduce high-level toxicity events, reduce acute care utilization, improve morbidity, mortality. So I think the hope is that while it is an extra visit, navigating to the second floor, no, it's not on the ground floor right next to the front door, I think, but it is navigating a complex healthcare system, a new specialty team paired with an already very complex specialty team. The hope is that visit helps to identify the individuals, the caregivers, the MDPOA, because those advanced care planning elements will be critical. And then eventually to have really a multidisciplinary support with oncology social work. And I think that's going to be a big part of what Dr. Clark and I do, is partnering with those different social workers of the different specialties in the cancer center and making them more part of our team.
We are out of time, but thank you everybody for coming and appreciate your engagement.